I am going to ask.
Turn on volume.
And so I'm going to ask um, Mrs. Natalie Hall Burton to say a word of prayer for us.
Are we on? How do I control my mute? Mute.
Please unmute your mic, Mrs. Burton. Please unmute your mic. Thanks. We're not hearing.
Yes, I've unmuted it. Can you hear me now? Can you all hear
Yes.
me now?
Yes,
Okay.
we're hearing. Thanks.
Yes. Just a little alteration. It's Miss Halliburton, not
Oh, it's
Mrs.
Miss. Okay,
Miss.
sorry.
Yes. Yes. That's okay. That's a natural error. That's okay. That's fine. Thank you all for attending. Welcome, Honorable Minister Tufton. We're happy to have you with us. Thank you for inviting us to your meeting. And we are looking forward to hearing what it is on the agenda and what we can do to contribute. So, without further ado, let us all bow our heads. So, I will share a few words of prayer. Um, Thank you, Father, for maintaining our good health, all of us, for being here, for being able to be here in good health and strength and wealth to hear what good words that will be shared in this meeting this evening, this afternoon. We thank you for your guidance and protection, for all that is going to be disseminated in this meeting this evening. And I thank you in your name.
Okay, thank you so much.
Amen.
Thank you so much, Miss Ali
Miss,
Burton.
yes, you can call me
Yes.
Natalie.
Oh, thanks, Natalie, for
Yes,
inviting the Lord's present in our midst this
yes,
afternoon.
yes.
At this time, I am going to invite our Regional Technical Director, Dr. Sandra Chambers. She will be doing a presentation on the status of COVID activities in the Southeast Regional Health Authority. And just to remind persons that the Southeast Regional Health Authority has the responsibility for delivering healthcare services in the parishes of Kingston, St. Andrew, St. Thomas, and St. Catherine. Dr. Chambers, could you proceed with the presentation? And I think if you wish to share your screen.
Afternoon, Miss Golden. Minister, good afternoon. And to all that's sharing us today in cyberspace, good afternoon. My name is Sandra Chambers, and I'm the Regional Technical Director for SERHA. I will be looking at what our regional status is. Can you see my screen?
Yes.
Yes, we are seeing
Yes, we are seeing it clearly.
Okay. All right. So the Southeast Regional Health Authority comprises of the parishes of Kingston and St. Andrew, St. Catherine, and St. Thomas. We have the responsibility for 92 health centers, 9 hospitals, 5 of which are specialist hospitals. We provide services to over 1.2 million persons, which is 47% of Jamaica's population. For Kingston and St. Andrew has a population of over 662,000, and that's the starting data, 2019. And a population of 65 years and older is 8.5% of our total population in KC, which is over 56,000. And they would have an active caseload of 556, a total caseload of 2,933. as of yesterday. So St. Catherine has a population of over 520,000 and a population of 65 and over 7.5% of this total, which is over 39,000. They would have had 760 active cases with a total of 1,793 cases. St. Thomas has a population of over 94,000 and its over 65 age population is 11.5% of that total, which is just over 10,000, almost 11,000. And they would have today 20 active cases of a total of 382. And this is just the epic curve that we're seeing and the increase as it spikes towards August and September. In SERHA, we would have a total of 284 hospital beds, 244 are general COVID beds, and ICU 28 and HDU 12. So we have a capacity to nurse 284 patients. And this does not include our recently acquired field hospital, which has an additional 80 beds. So, so we would have now looked at what is happening in Jamaica. Jamaica first diagnosed its first case on the 10th of March, and that was diagnosed right here in SERHA. As of yesterday, Jamaica would have had a total of 8,067 cases. SERHA has 5,107 of these cases, and this is 63% of the national total. So you see SERHA has the lion's share of all the cases. KC has 57% of all of these cases, 2,932, while St. Catherine has 1,793, which is 35% of the caseload. And St. Thomas only has 8%, 382. The total deaths in Jamaica to yesterday was 1,151, 151 deaths in Jamaica. Of this, SERHA has 85, and this is 56.3% of the national total. KC again has the largest amount of deaths with 55% of the deaths. St. Catherine has 44% of the deaths, and St. Thomas just 1% of the deaths. The female population has the greater burden of the disease and death. So the female has more COVID infection, and they're dying more from, the male 55% of the deaths, and the female 45%. If we look at the number of cases by month, we would see that September was an extremely active month where we would have had over 2,662 cases. We're looking at now the age distribution. We recognize that the age that is affected overall in SERHA, we find the greatest burden, the age 36 to 65 with 39%, over 65 years with 26%. The 16 to 35 just has 19. And of course, the younger children under 15, only 9%. You would have noted here that we're having an increase. Now, if we look at the cases, for KC, you would see that the population that is affected mostly, the 16 to 65 age group would have had the largest share of confirmed cases, which is 36 and 38 respectively. And if we put them together, this is over 70% of the cases. The over 65 year only has 9%. Of importance, of interest, you can see that our 0 to 5 population has a 12% share of the pie, but this is just KC. The other parishes, you see, this population is very low, but in KC, 12%, that is kind of a little bit significant. All right, so if we look at St. Catherine, but St. Catherine has a similar picture. The age group 16 to 65, again, having the brunt of the cases, 41% for the 16 to 35 and 39% to the 36 to 65%. The over 65 only has 10%. And then if we look again here, I think it's female that is champion in the cause here. And for St. Thomas, so here we would have the male, female. Female has more cases here in St. Catherine. So when we look at St. Thomas, for St. Thomas is a similar picture. Female, 229 versus the male 153. If we look also at the age group affected in St. Thomas, it's a similar picture. 16 to 65, it's the age group that seems to be most affected in SERHA. If we look at the over 65 age group, we'll see that the 60 to 69 age group has 53% of the cases, and the 70 to 79, 28.8%. The 80 to 89, 14.7%. Now let us look at, the deaths. All right, so we come to that. If we look at St. Catherine, this is Kingston and St. Andrews map we're looking at, and the colors would indicate the number of cases that we have. The white areas are areas that we're not having any cases just now. The light pink area, we would have 0 to 1, 1 to 4 cases in those areas. But the area of concern that we may notice is we have here Whitfield Town. It's just right here that we were just doing some activities in over the past 14 days. And then if we look down here now, we see coming up Raytown is coming up red on the map, it's red. So the two reddest area we have is Whitfield Town and Raytown. And we have now Mountain View Vineyard Town, it is coming up here, right here. And then we have Lawrence Tavern. So that's an area that we need to put some focus on. If we look here, Constant Spring, Barbican, and Ligony is also another area of concern that we need to put in strategies to deal with. The other areas, the cases are just scattered. Nonetheless, we still have to focus on all the areas to see how soon we can get the areas right. Now for St. Catherine's map has its case all over, scattered. Almost the entire St. Catherine has cases with just a few areas not yet touched. Areas of concern in St. Catherine, Waterford, red area, that's where we're operating now the last 2 weeks. Greater Portmore is another area we need to look at. Old Harbour, but let us not forget Linstead. Linstead is the reddest zone. Linstead is a wide, extensive area that seems to be quite red now, with a number of cases that we need to know, focus on, and put strategies in place to really get these numbers down. We have started working in Linstead, and we will continue because it is an area of concern. Now this map is St. Thomas, and I wish all my maps looked like this. We only have a few areas. If you all remember that we had problems in August in St. Thomas, and the intense activities that took place there was able to significantly reduce the numbers in St. Thomas. I'm very proud of my colleagues over there. They're only having 20 active cases just now, and those cases are scattered in these 2, 4, 5, 6 community. And so I have charged them to ensure that the next time we do a review, all of St. Thomas becomes white. So as we go ahead and we look at our deaths, where are we seeing our deaths? The age group that we have the greatest problem of our deaths is right down here, starting from between the 50 to 59, we have 15.3% of the deaths, 60 to 69, 17.6%, and the 70 to 79, that's a problem, 30.6% of the deaths. The 80 to 89 has 12.9%. The over 90 has 9.4%. And of course, we know why that is so low. We don't have too many persons living over 90 just yet. We are just increasing our life expectancy. And so if we look at the case fatality rate, the highest case fatality rate is observed at over 90, the 80 to 89, 70 to 79. So if you look at the over 70 age group, that's where we have the highest case fatality rate. And this is just a depicting of the pie. So if you look at this large area, the greatest portion of the pie, 70 to 79, 30.6% of our deaths. And of course, of importance, the majority of our deaths are these elderly persons, which are the most susceptible age group, having more than one comorbid conditions. And that is why we have to be careful and protect this vulnerable age group. This is now for, we're looking at the sex, and what is the sex that is affected most? The male species. 55% of our deaths are in men. And this, well, earlier I showed you that in September, we had the largest number of cases, and also in September, we had the largest number of deaths. We had 55 deaths in September. For October, we just have 14, but the month is young yet. What have we been doing and what have we done to try to curb some of these issues that we are seeing? So we would have, this is our testing bus. We would have embarked on from the ministry's level in terms of setting out protocols and how we manage this activity. As a region, we would have engaged in training and sensitization sessions in different settings. We would be looking at the workplaces, schools. We would have targeted community interventions, both face-to-face and via social media platform. We would have disseminated messages to speak to sensitization, sanitization, mask wearing, social distancing. We would have had the assistance from NHF assisting us with town criers to take the message around. We distributed a number of IEC material related to COVID to businesses, school, workplaces, health centers, and persons on the road. We would have conducted focus group discussion with different age cohort just to ascertain their perception of their risk, because a lot of them do not perceive themselves being at risk for COVID-19. This is our team in Waterford doing their community surveillance. We would have been initiating a number of measures to see how best we can manage the spread and contain it. So we would have been doing our health screening, various level of health screening, and the quarantining of persons arriving through our ports of entry, our airport and our seaport. Public education and sensitization session of the public and the vulnerable population, and the community quarantine. Promoting mask wearing, sanitization of hand, sanitization of frequently touched areas, and social distances. These still remain the best methods to prevent the COVID-19 infection. We have a number of public relations, video, newsletter, publication, social media presence, environmental health inspections, and enforcement of regulations for institutional health, food handlers, establishment, schools, business places, and infirmaries. We are conducting testing to diagnose persons with COVID, contact tracing, so we can identify and isolate persons affected early. And this is in an attempt to slow the spread. We have conducted several community surveillance and looking for persons, symptomatic persons and vulnerable groups to have them test and identify them early, put mitigation measures in place to prevent death of these vulnerable groups. In order to reduce the morbidity and mortality of these persons once we would have diagnosed them, the government, by the leadership of the Honorable Christopher Tufton and the Minister of Health, would have assisted the regions and the facility so that we could strengthen our secondary care facilities. We would have increased our bed capacity, our capacity to treat persons with COVID-19, increase our ventilator capacity, training of healthcare workers, facilitating mental health support, and staff welfare activities. And so these are just some, our team in the field. Our inspectors would have conducted a number of inspections, EPO, schools, nursing home, prison, lockup, etc. And we are collaborating with a number of NGOs and government organizations in health promotion, community interventions. And the NHF is also partnering, a strong partner with us in a number of activities. PSOG has also partnered with us. Church leaders has partnered with us. The media houses have also partnered with us. And so as a group, a join up approach that together we can be strong and together we can fight and combat this COVID-19 epidemic that is upon us. Wash your hands, sanitize, stay far, social distance, and isolate when you're ill. And on this point, I end. Keep safe, stay home. Thank you.
Thank you so much, Dr. Chambers, for your presentation. Before we embarked or are engaged in our question and answer segment, I am now going to invite our Minister of Health, the Honorable Dr. Chris Tufton, to take over from here.
Okay, thank you very much, Mrs. Golden, and good afternoon to all concerned. Thank you very much for coming online. The last check, there were about 115 persons online, and I'm presuming from the two key parishes of St. Catherine and Kingston and St. Andrew. We appreciate the time taken to come online. The beeps that you're hearing are additional persons coming on and asking to enter the meeting, so the numbers are going up. This is the final of a series of meetings that we've had via Zoom across the country, targeting community leaders, persons who have influence within the communities they reside or within the entities that they are a part of, you know, the service clubs, the chamber, the ministers fraternal, persons who have a platform to drive an agenda around behavioral change, persons who are respected and can offer some influence. And these persons, and we so far have spoken to about 500, with your addition that would go over 600 or so, 600 plus, are individuals who we wanted to have a conversation with around the status of COVID within your particular parishes and where we are, where we need to go, and then afterwards to ask for your engagement in the process as Jamaicans and as key influencers, and then, of course, allow you to ask some questions. So I'm going to go right into it. The presentation was intended to give you an overview as to this, where we are now in these parishes. But I wanted to use that context to define a couple of things quickly. First of all, we are in community transmission. And that community transmission phase, simply put, means that the virus is here, there, and everywhere. The virus is a lot more present in your communities, in your spaces, whether at the workplace, whether at the supermarket, whether on the street, in the marketplace, and indeed, even in your homes. The asymptomatic positive case is hard to detect, and in fact can only be detected with a fairly accurately, or most accurately, with a PCR test. And that's the one that we're doing now. We're going to introduce others. But that assumption of the virus being more wide scale across the country requires a particular response. And it's a response we've been driving through mainstream media, but also at the community level. And it is something that we're trying to improve or increase the awareness of. And by so doing, driving the response, the behavior, and the role of every single Jamaican. All of us need to play in addressing it. The fact that the virus is everywhere says a couple of things. One, you can't take anything for granted. In fact, it's saying that you must assume that everyone you come in contact with is a potential carrier of the virus. Everyone, barring none. Your best friend, a family member, or otherwise. And that is very, very important as an assumption, because it is that assumption that drives the policy arrangements that the government would have advanced and articulated. And one of those key policy sort of posture or position is that we have to now find a way to coexist, if you will, and I'm trying to be as simplistic as possible, with the virus. And so taking some of the very drastic actions that we would have taken in the past, for example, shutting down an entity because a case is discovered, is perhaps no longer as useful or valuable, because you probably would be shutting down every single day, because every day you're going to find somebody else. So the idea is, how do you live with the virus in these circumstances under the community transmission phase in a way that consistently prepares yourself to minimize the risk, but once the virus is discovered, you can address it quickly and carry on. So the issue of a workplace, as a case in point, means now that if you find someone with the virus in your workspace, it's not an automatic decision to shut down and deep clean, because under the current arrangements, the assumption is that you will consistently clean, that your employees will wear their masks consistently. By the way, I took off my mask a while ago just to be very clear in my articulation, and there's no one close to me, so I think I just want to make that clear. And that the 6 feet distancing is observed, the sanitization is observed, because there's no silver bullet that's going to address minimizing the risk. It's a combination of things. And because of the prevalence of the virus, people still have to eat, people still have to go to work, and so it's going to require us to do things differently, recognizing that in a sense we have to coexist until we get to the point when the virus is dealt with either through modern technology or otherwise. So shutdown, for example, is no longer an issue that we would... Sorry, there's an issue. Okay, I'm told that I'm not communicating. Is anyone hearing me?
That's what have been happening. Some of the other moves. And then I know it look like them not working. Okay, thanks.
Yeah, I'm hearing.
So someone is hearing? I was told to hold because of the sound quality. Is anyone hearing me? Just doing a technical check. Miss Golding, are you hearing me? Miss Golding? Is anyone hearing me? Miss Golding, are you hearing me?
We're hearing you now, Minister.
Oh,
Yes, sir. We're hearing you now, sir.
okay. So the all right. So I'm
hearing
trying
you
to
now,
determine
Minister.
where I lost the audience. Should I begin from the? Should I start from the top again?
Minister, it would be useful if you started from the top again, Minister.
Okay, great.
Yes, sir.
All right, let me quickly go through. So I started off by saying I took off my mask, right? And I'm in safe space with not many people around me and within the 6 feet distancing, just for clarity of expression. But secondly, I was saying that the context that was presented earlier needs to now add to that the phase of the virus that we're in, which is the community transmission phase, which I'm sure you would have heard of. I'm going to ask those who are not, I'm going to ask others to just mute your mic, please, because if you have your mic on, then it becomes a problem. Thank you. Right, so we're in the community transmission phase, and the community transmission phase really means that the virus is here, there, and everywhere. And there's an assumption, an implicit and explicit assumption that we must always factor in the way we move, the way we conduct ourselves, which is that the person next to us could possibly be a carrier of the virus. And the way that assumption would drive a behavior that would reinforce the concepts of wearing the mask, of the 6 feet distancing, of the sanitizing. It would also shift the focus from what used to be the case, where we would shut down an entity when we found the virus, to deep clean, and instead move towards consistent and more frequent cleaning. And failure would not be that you discover someone within your entity or community with the virus, because it is so prevalent. Your success is what systems you have in place to respond to a positive case, if that positive case is detected, so that you can continue normal life and living as we know it. And that's a very important distinction, because what we're doing is shifting the focus from the heavy restrictions to almost living and coexisting with the presence of the virus by taking the precautions that are necessary, while of course treating those who may be impacted. Now, in this community transmission phase, you're going to find three sets of persons who are positive. One is the asymptomatic positive, who will be at home or would be recommended to stay home to isolate until they're better. And in the past, what we would do is do 2 negative tests for that person to now be allowed to go out and say they're clear. Right now, it's really just 2 weeks in isolation, and then they can go about their business. So there's no test that is done, and certainly no 2 negative tests, as was the case in the past. The majority of persons who are positive would be asymptomatic, and so the majority of those who are recovering would be within the communities, would be your next door neighbor, maybe in your house, but they are isolated by a particular protocol, so they stay in their room and that sort of thing. And that's the overwhelming majority. There's a second group that may not have the convenience of an isolation room in their home, or for whatever other reason may require some care and support by a medical team, but they are not placed in a hospital because they don't need that kind of care. They're kind of in a halfway house. You know, we release a property, a hotel or a guest house. You have some nurses there and they attend to those persons. Incident, also, the persons at home would still need to communicate do their daily temperature checks, communicate with the health centers, and so on. The third set are the set that are requiring of hospital care. And hospital are reserved for those who need hospital care. So those are the clinically ill that require the doctors and the nurses full time. They may need the ventilator or certainly close monitoring. That represents the minority. Right now we have just over 100 plus persons who need that type of care. And that, thankfully, we will try to keep that way, because the last thing you want is for the health system to be overwhelmed. But what those three categories of positives demonstrate, particularly in community transmission when you have a lot of more persons, is that the presence of COVID or the virus in your community is quite real. And it's likely to be the case in most communities across the country. And it's not therefore wise to stigmatize or to discriminate, because that helps none of us, because we're all there now, uptown, downtown, or midtown. And therefore what we have to do is to work together as individuals and as communities to drive the response that will see us all overcoming together, or frankly speaking, all failing together. And that's very important. And this is why an audience such as this one is so important, because you already provide critical leadership in your own way through your particular entities to the communities where you reside or where you provide service, whether through the church or the service club or through the chamber or otherwise. Beyond those three categories, we have a subsets of the population that are worthy of recognition. The first is the most vulnerable population. And the more vulnerable population would be the older population and those with comorbidities. And what is very important is that within the context of the community, those vulnerable populations need to be given added protection, additional protection and support. And that's also very important, because if you take a community-based approach, you're going to have to almost discriminate in favor of those populations, and discriminate in a positive way now. You're going to have to give them additional support, whether through the messaging or other forms of support, which I will get to shortly. Now, the younger population, the more youthful population, may not be as vulnerable to the virus if they get the virus, but they become super spreaders potentially, because they will have a common cold, but they'll take the virus into the homes to their mothers and grandmothers. And we have had cases where that has happened, and we have had cases where the grandmothers and mothers have died because the child took it home unknowingly. Clearly nobody wants to hurt their loved ones, but take it home to those persons who have gotten it, and because of their comorbidities or otherwise, they end up suffering the worst from the virus. So the message around protecting the vulnerable must also include a message around making the youthful population more alert and aware, and influencing their behavior so that they can protect the community and those that they interface or interact with to play a key role. What this is saying, ladies and gentlemen, is that the approach to COVID, particularly at this stage, the community transmission phase, is an approach that requires every single one of us to play a role. I mean, barring none. We all have a role to play. Government alone can't do it. No particular entity alone can't do it. Everyone has to define a role. What it is saying is that it is around behavior and behavioral change, supporting the protocols, getting people to adjust to the new norm, if you will, that is going to make a big difference in how we manage this community transmission phase and minimize the critically ill and the deaths in support of all of us. And the extent to which we do well is a function of how we play our role. And this is not an excuse for government and what government ought to do, because the government is very committed to the program, but it is the reality of what a pandemic of this kind, a highly contagious pandemic, what it does and potentially can do if we do not take the necessary action. So it's very important. You probably need to stay there and monitor it for me, or whomever, okay? So it's very important for us to recognize the critical role that we all have to play. Now, the ministry has rolled out a few important programs to try and address the challenges of the community transmission phase. The first program is one around the vulnerable that are impacted mentally. So mental health becomes absolutely critical. And one of the reasons for this discussion is to really challenge and charge the leadership in our communities at the parish level and otherwise to be part of a response that will seek to provide support, guidance, enhanced coping mechanisms for those who are impacted. And mental health has been demonstrated with studies that have been done to date, not just in Jamaica but globally, to be a major sort of side effect of the COVID response. So on one hand, we say to people, stay at home if you don't need to go out. And the older population, for the most part, have complied. Some of their relatives and friends who would visit them no longer do because they are fearful that they may be transmitting the virus. They themselves have issues with children being at home. So what you find now is the creation of a disconnect between the older population, and the consequences of that are loneliness, depression, and all the associated mental ailments have been enhanced. We have had situations, Professor Eldemire Shearer have said that some of her patients have lost their motion because they would walk around each day and do the daily exercise. For the last 5-6 months, they have not gone outside, and it has had an impact on them. Some are impacted by, the support that they would normally get being absent for helping them to buy groceries, for getting their medication. And there's a real issue in the society now where the mental health of a fairly large segment of the population has been impacted by the radical shift in demands or restrictions around their behavior and around their movement. The young people are similarly affected because many of them are no longer able to play with their friends. These are the schoolers now, because of the work from home. And the family environment is being impacted by some of those very restrictions that are to secure us from the virus, but at the same time are having added effects on our lifestyle as we know it. So that's one issue that is very, very big. The other is the burnout of our health workers, which is why we announced the welfare program. These health workers have been working for the past 8 months, and it has been difficult for them. And many have been working many hours non-stop. So we have a program that is developed to bring more on board, but also to give them an opportunity to re-energize, to continue the work, because it has been very difficult. And then tomorrow we're launching a program around young people, youth. And that is to recruit young leaders to be a part of the solution by understanding their particular role in this response. That they don't become super spreaders, instead they become protectors of the community and those in the community who are most vulnerable. And more will be said on that as we unveil that plan tomorrow with a large set of young leaders across the country. This group I want to finally throw out a charge to, and this is around providing support at the community level in a deliberate way for those who are most impacted by COVID, starting with the mental health issue. We have launched a program that will provide an online training arrangement working with the Pan American Health Organization. We have a manual, and the intention there is to help normal people, not specialists, to understand the signs of mental health issues, to provide an opportunity to assist those who are so impacted at the community level in a way that is safe with an appropriate protocol. So we still maintain the distancing and the masks and so on, but we help people to overcome loneliness. We help them to express themselves, give them an opportunity. We help them with their supermarket shopping if necessary. We encourage them to walk around the house, not just sit down and not do anything. And where they need additional support, those individuals would be sufficiently trained to at least pick that up and recommend them for additional, more technical support through our mental health unit, whether through the mental health nurse or the doctor, the psychiatrist, or otherwise. We have a toll-free number that is out there. Promoting that number is important. There are elements of the program, for example, that we will prescribe for consideration, such as a community COVID conversation, where we have defined as 6 persons coming together for a discussion. So one is the moderator or the person who is providing the leadership, another 3 to 6 sitting down in a setting, whether on a veranda, under a tree, or somewhere else, and just having a conversation that engages persons who are vulnerable and helping them with the coping mechanisms that are necessary to overcome this period. And the training will provide you with that basic information. So right now we are on a recruitment drive. We're asking leaders to participate or to help to recruit persons who will participate. And we're going to be advertising for persons to be in touch with us. We would like to create a chat group in this group so that we can communicate with you. And if you are interested to further the dialogue beyond today. And again, it doesn't require a lot. Many of you are doing it anyway. I mean, the church is a big social institution beyond the spiritual. There's a lot of outreach that takes place. The pastor, particular members, the service clubs do the same thing. The JP does counseling, I'm sure, many times. And I could go on. The political representatives, the counselors who are in the communities. What we want to do is to create an all-of-society approach. And we want to create the spirit or rekindle the spirit of volunteerism that can get persons involved and play a role with appropriate guidance that we will provide. And this mental health response does require volunteerism and requires as many Jamaicans as possible to be a part of the program. So ladies and gentlemen, I'm going to stop here. I have hopefully given an overview as to the community transmission phase, the need for all hands to be on deck, for everyone to get involved, and for guidance that we will provide as part of that response as we seek to advance the process to the next level. I think we're doing well as a people and as a country. I think we have overcome many of the challenges, and by any standards, globally, regionally, or otherwise, Jamaica is doing better than most. But one death is one too many. One sad face or someone impacted in one way or the other is something we want to avoid or at least minimize. And I think this phase is the phase that requires a true collaboration as a people, where individual responsibility is key, but also being our brother's keeper is very, very important to advance this agenda. So I'm going to stop now and ask for questions. You can use your hand-raising knob on your system, and I'll be happy to take any comments or questions, and we can proceed in that respect. Thank you very much.
Thanks.
Okay, Ms. Golden, we need to see where the hands are up. Just adjust the screen for me. Click on participants for me, please. If there's anyone who is interested to make a comment, please go ahead. Just identify yourself, and we're listening.
Go ahead. Good afternoon, all. Pat Donwell, Custis of St. Andrew. Dr. Tufton, what telephone number should we call for volunteers, for those who will volunteer for the training?
Okay, so we have you can get in touch, Costas, with the ministry through my office or the mental health unit. I don't have the number right now. We were going to be running some ads both on social media and in mainstream media to promote not just a telephone number but also an email address. So we will provide that very shortly. What I'm planning to do with this group is to provide, we're going to take all the participants and we're going to create a WhatsApp group. All you need to do is silence it, so if persons are commenting, it's not beeping on your phone all the time. And we're going to send some messaging through this medium, so that persons who are interested can express the interest, and persons who may want to help to recruit can also do so and communicate with us. But over the next few days, we're going to be promoting an email address and a telephone number to advance the approach for volunteers, and then organize a training session in short order beyond that. Okay, anyone else? I see another hand up. Gentlemen, can't you fix this so I can see the... Thank you.
Good afternoon.
Good afternoon. Just identify
O'Neill
yourself.
Thomas here. Good afternoon. I applaud the move to keep in check the whole issue of mental health during the COVID-19, and my concern really is for the many children who are still not adjusting to life at home 24/7. And personally, in my community, when I go around, I find that many children really can't cope. You know, some, when you speak to them, are in tears, and some have even threatened, the whole issue of suicide. I'm sure you read in the newspaper the other day that a possible case of suicide due to depression and so on. So it's a very good move. And I'm hoping that not just relying on volunteers, but maybe there could be a structured program that could be implemented virtually in the school curriculum or agenda that would address that.
Okay, just to say that there is such a program, because there's a recognition. We've seen a few studies, like a UNICEF study that speaks to that age cohort that are schoolers up to high school, as well as other studies that have shown other age cohorts having similar issues. So it is, this program that we have will utilize the professionals, our own professionals in public health, as well as the education platform to help to guide the process and help with the coping mechanisms. The volunteerism component of the program, which we're discussing now, is an attempt at getting the community to engage the process, to provide the support in a way that is not difficult to do, just some very basic guidelines, because you'd be surprised, a lot of persons just need someone to talk to. They just need to express themselves. They just need to highlight their issues. And it goes a very far way in helping them to cope and to overcome the loneliness that may be a problem, or the depression or otherwise. But the technical team, it is envisioned, will be available to intervene as is required based on the sort of preliminary diagnosis of what that person is going through. And that will all be captured in the online training.
Thank you, Mr. Minister.
Okay. Anyone else?
Your laptop, sell out your desktop or don't make them. It's an investment.
All right. So, is there anyone else who would like to make a contribution?
Perhaps, Minister, perhaps not with respect to the program you're talking about.
Okay.
My name is Pauline Archer, St. Andrew JP. Just with respect to the hotlines, I don't believe they're effective enough.
Okay.
I have had experience to be calling the hotline. Most of the numbers give a recording, and the 888 number goes to a recording that tells you to wait, and you wait for 38 minutes, and then it is cut off.
Okay. This is the
So
mental.
that is something
This is the COVID line or the mental health line?
The COVID line, the COVID line,
the COVID
at the
line.
ministry.
Right. So we will check on that, because I think we have quite a number of persons manning those lines. It's not exactly the same for what we're promoting here now. The mental health line is 888 New Life, and that line we have boosted the capacity to respond. We have seen an increase in the numbers in terms of persons using the line. For those who are not speaking, just mute your mic for me, please. We're getting feedback from persons who are not speaking and having the mic open. So,
Minister.
Yes.
Minister, this is Errol Holmes. There are a few questions in the chat. Perhaps somebody could direct you to those as well.
All right. Let me check on that. What we will do, as I said earlier, is support the response through a group that we will establish with all concerned. But if anyone is online and have a question, just voice that question so we can hear. And the region is online also.
Dr. Tufton, just another question.
Yes.
And maybe you can answer anecdotally. I note the colleague's presentation with regards to areas of Kingston and Jamaica with very low instances of COVID to perhaps none. And I'm just wondering, what are they doing differently than the rest of us? That's one. And the two, I've also observed in the field from time to time that some of the persons who are sent to do the investigations and in the communities and so on, they're not as thorough as they should be. I've observed, for example, they go to a particular community and they ignore another side of the community. I'm saying, but there are other houses and places elsewhere, and they say, well, the map they were given only shows these number of houses, and they don't go. And I'm saying, but persons live there. You need to go and conduct your search and your checks there as well, because it's still a part of the community. You know, so
this is
not just a hotline that needs tightening up, I guess.
This is for COVID or for
COVID?
For COVID. Well, what we do, we have a very strong epidemiology, and they map all the cases that come in, all the cases that they treat, all the cases that they discover or diagnose, map them by addresses, so we know exactly where persons are, and then they do contact tracing, which means really interrogating those individuals who are positive, interviewing them, if you will, and following through on who they are closely associated with to determine if those persons need testing and or quarantining or otherwise. It is based on the mapping and the contact tracing that determines the color coding on the geographical map. And you know, we that is real information. We do random checks also because we have 325 health centers across the country. And the idea is for a health center to be no further than 10 miles from where a house is. Or we do build homes in remote parts, so I'm sure it's not a perfect arrangement. But the health centers are supposed to provide additional support at the primary community level. And where persons have symptoms or issues, they either deal with it by collecting samples or recommend that those persons go to the other closest point for sample taking. When the antigen test is introduced, hopefully in another few weeks, it will be a much easier way to test. And I think it will give us a better indication because there is an assumption, and community transmission confirms that more than any other phase, that what we turn up as positive cases only represents a fraction of the number of positive cases out there. I mean, you don't know all the cases, and there are many more cases than what you find, what you have in your database. And particularly if these persons are asymptomatic, they will have the virus, get better, and you'll never know that they had it. And that is universal. It's not just about Jamaica. So the point I'm making is some of those areas where you see nothing as if the virus is totally absent is not necessarily the case. But it is our best guess based on the information that we get or we collect. Any other question? Just identify yourself and ask.
Minister?
Yes.
Here, there is a question in the chat.
Right.
About from Odin White asking what is the latest regarding the vaccine, the COVID vaccine.
Okay, so the COVID vaccine is well, Jamaica took a decision at the level of the government, cabinet, that we would be part of a group of countries, over 100, I think closer to 150 or so, that are going to pay into a fund under the auspices of WHO PAHO to access a certain quantity of vaccines once a reliable, safe vaccine is discovered. There are a number of countries, private and public sector in some cases combined, that are doing research on vaccines of one form or another. Some of them are in Europe, some in the US, and other places. So the payment into that fund, which would entitle us to 10% of our population, so we would get 270 or 280 doses, and that will be dedicated more to frontline workers and vulnerable populations. And then beyond that, we can buy more. That is not linked to any particular vaccine. It's linked to the discovery of modern science of any vaccine at all that comes out and is validated and is deemed to be safe. So we really are waiting on those research and efforts that are taking place. Right now, I know of none that is available. In fact, the latest news that I saw in the case of 2 attempts were that there were some setbacks because of side effects related to trials. And so when you have these things, they have to assess it and they have to continue the effort. So the short answer to the story is I can't tell you how long it will be. I know there are efforts going on, and the commitment that we have made is to be in the line to access some of those over time once one is available. Ms. Golin, what are the other any other questions?
There's another question from Mrs. Lisa Soares. She's asking if you can share more plans for implementing telemedicine in a big way to take off the pressure of the system. And she's also commending the ministry in terms of in terms of the COVID management so far.
Thank you very much for that. Again, the success that we will have depends on all of us, and that hopefully is the message that we want to leave all of us with this evening. Any other question? Ms. Golden, just read them out for me because I don't have access to them here. Or if anyone else has a question, just raise it. So I'm going to summarize because I know we've been at this for a little while. And
Yes.
yeah, go ahead.
Hello. Good afternoon, Mr. Minister.
Yes, good afternoon.
Andrea Christie, Director of Nursing Services from
Hi, go ahead.
Sir John Golding Rehab Center. Just want to ask, our access for persons with disabilities and how inclusive are other health services associated with COVID-19 for these persons?
Well, there's no discrimination around the services that we offer for COVID patients. The fact is that once we go through the testing process or we assess the risk and persons are high risk or have actually contracted the virus, then the public health system triggers an approach that is multifaceted: contact tracing, isolation, and a determination as to where you put the persons depending on asymptomatic versus symptomatic, and of course treatment in the system. Persons with disabilities would be considered a vulnerable group, just as persons in institutions would be, the prisons, the infirmaries, as well as the persons with comorbidities and beyond a certain age cohort. So we have defined the vulnerable groups in a way that captures a number of subgroups, and those persons would be given particular care, and persons with disabilities would fall in that category. Any other question? Go ahead.
Yes. Minister Tufton?
Yes.
Can you hear me? Yes. Good evening, afternoon, sir. This is Natalie Halliburton from the St. Andrew JP. Question. In last night's TVJ news, it was reported that there are certain persons in a particular area that is now under quarantine. They are refusing to participate in the COVID-19 testing. That poses a risk. So I'm asking, based on that report, what are you and your team planning to address issues of this nature?
Well, right now the decision as to whether you want to do our test or not is not a one that the law compels or forces you to do. So it's a choice. And what we have done is use moral suasion to influence persons, particularly in the quarantine zones or high risk areas or high risk individuals, to do the test. Some of the persons have said that they think it's dangerous, it's uncomfortable, and you get these particular reasons. If persons are deemed to have symptoms and clinically diagnosed as being a COVID suspected case, then the authorities could move to quarantine those persons and isolate them, even without doing a test. I mean, we've done that in the past with persons who have had to come in and quarantine and who have a quarantine order and breach the order, and we've used even the police, the constabulary, to detain them and to keep them because of the safety of the general public, persons that they'll come in contact with. So we can get to that extreme, but that is based on a clinical assessment, even without a test, and that can be done. But we certainly want to encourage other persons to participate in the testing when the clinicians assess and feel that a test should be done. And it doesn't mean that they're symptomatic. It could just mean where they reside.
Precautionary measure.
Exactly. Okay. All right. Any other questions?
Thank you, Minister.
Thank you.
And this is just the first question. I'm not sure if I think you did not address that question. Can you share more plans for implementing telemedicine in a big way to take off the pressure of the system?
We're doing the health information systems now, which will mean digitizing or establishing a technology platform in our hospitals and linking them to clinics or health centers. When that platform is established, it will make telemedicine a lot easier to administer. We are doing a couple of experiments now, or trials, with telemedicine between the University Hospital of the West Indies and a few health centers in rural Jamaica. and that is part of sort of regularizing, if you will, the telemedicine platform. But the real change is going to come when the health information systems, which the government has funding for under IDB window, and a project that is now actively being implemented, when that comes on stream, it will provide a basis for telemedicine. All right, so if there are no other questions, I'm going to close the discussion by firstly thanking all of you for coming online. But secondly, just inviting you, when you are placed in this group, for us to communicate with, and I would like to be able to send you information on what is happening in your parishes. That if you wish to delete yourself from the group, feel free. But otherwise, those who want to be more active as part of the volunteer cohort, particularly around the mental health mission that we have spoken about, the support systems, if you will, at the level of the community, then please indicate so when you are contacted. There will be other information placed in the public space around recruitment, but otherwise you can do your regular outreach that most of you would have done anyway to encourage persons who are suffering and who need that type of support and help. So I want to thank you for joining us. This evening at 6, we have our COVID conversations, regular COVID conversations, and we're going to be discussing a youth profile and the role of youth and young people in the COVID response, and also giving some updates on the staff welfare program, as well as looking at the country generally. So please tune in through the ministry's website, online, or through public broadcasting TV for the COVID conversations, which we normally have on a Thursday evening, where we give additional support. Thank you very much. And Ms. Goldin, I don't know if you want to add any final words, but let me say a big thank you again to all who are online.
Minister, I know you basically have closed, but somebody is asking, what age group are you looking at? I guess in terms of volunteerism.
All age group, all age groups. I mean, we're not discriminating. We want the young people to be a part, which is why we're launching this youth group tomorrow. This is those who have just passed the high school age onwards. But anyone who is willing to reach out it's important. And again, there are protocols around that reaching out, because we're not sending persons in harm's way to risk themselves around the virus, but just to provide critical support. There's no age limit.
I know we want to close, but somebody's also asking, is the Jam COVID form still effective?
The Jam COVID site? The Jam COVID site is still being used. There, from time to time, there are issues, but we try to work those through as quickly as possible. So depending on whether you're a Jamaican diaspora coming home, you have to upload on the Jam COVID site. If you're a business person, similarly so, which requires you to do a test on arrival. Jamaicans are quarantined for 2 weeks. And if you are a tourist, then you do a test in that market. It's checked, and once it's confirmed by the airlines, like showing your visa basically, you still use the Visit Jamaica site to upload your information. But when you arrive in Jamaica, you go to the corridor, which is defined, the hotels, that space where you stay. So yes, the Jam COVID site is still being utilized.
Just lastly, Minister, is there a special training for the youth volunteers? Who should they call for further details? And right. Somebody is also asking that we have or convene bi-monthly forums like these.
Okay. So on the youth volunteers, we will provide better
training for the youth volunteers. Who should they?
Right. So we're going to provide better.
Go ahead, sir.
We're going to provide better particulars on the training that will take place. We are having a session tomorrow at, is it 1 o'clock? 1 p.m. at the Jamaica Conference Center, where we will have a number of youth leaders in a social distancing context and many others online. So it's going to be also a Zoom meeting. And we have a few experts who are going to speak about how young people are impacted and how young people can be mobilized to play a part in the COVID response. So that will be a sort of a training, and we will promote the Zoom link. We will promote the Zoom link for it will be streamed live. So we'll promote that for anyone interested to come online and to get additional information. All right. I think that was the question.
Okay.
Right?
Yes, sir. Somebody was just asking to share the Zoom link, but you said that, same will be done.
No, that's
All right, I understand if you go into the WhatsApp chat group, the chat on Zoom now, you can join the WhatsApp group now. Persons who are interested in joining, just click on the link, and it will automatically update you. But we'll be in touch otherwise through the region. Okay, Ms. Golding?
Okay, yes, sir, we will. So I just want to join the Minister of Health, the Dr. Honorable Christopher Tufton, in thanking persons for being a part of this very important conversation. And of course, I will share the Zoom link for tomorrow's forum. Thanks again, everyone.
Thank you very much. All the best.
You're welcome. Thanks for the invite, Ms. Golding.
Thank you. Thank you for having me.
You're welcome.
Thank you, Ms. Golding, for inviting us.
Thank you.